Good afternoon. I'm Ed Isakson. I'm Human Resources Director for the Archdiocese of Indianapolis, and it is a pleasure to be with you today. Co-presenting with me is Amy Ball, who is our consultant with Health Strategy, and I'll just be leading off, and Amy will take over from there. Next slide, please. Our agenda today is to give you a better understanding of our pharmacy benefit, to talk a bit about Health Strategy and how we've partnered with them to help reduce our pharmacy trend. Amy will go into that trend and how we're seeing improvements. Also, to talk through the RFP process and our goals. Certainly mitigating our trend in the short term is important, but we took a long-term perspective as to how we can develop strategies that on a going forward basis will help to flatten our cost curve. And also contractual flexibility. How do we look at working with vendors who have innovative solutions and can be creative in terms of how they provide value for us and for our members. Next slide, please. A little bit about our health plan. First of all, the Archdiocese of Indianapolis is made up of 125 parishes and 68 schools over 39 counties in central and southern Indiana. We have roughly 2,800 people on our health plan, and our plan is grandfathered. In 2008, we adopted a high deductible plan design on a full replacement basis. So that was rather innovative at the time, but since 2008, we've had one plan option, that being an HD-HP. We're grandfathered because it hasn't changed since the ACA was enacted. There are essentially two populations we serve with our health plan. The first are the lay employees of the Archdiocese. The high deductible plan has a $2,500 individual deductible, $5,000 family deductible, then 30% co-insurance thereafter. One thing we do is contribute to our employees' health savings accounts, $100 a month single, $200 a month family, to assist them with costs that they incur. Our clergy population has a different plan design. They have no out-of-pocket costs. So when it comes to helping them use services more effectively, we work with Amy on devising some strategies to reach out to that population. In terms of our plan design, we're seeing some good results in a traditional sense. Our generic dispensing rate is close to 90%, which, as Troy mentioned, is where things typically are getting these days. So we're satisfied with that. 70% of our maintenance meds are filled with 90-day supplies, which gives us better discounts and lower dispensing fees. But what we've seen, certainly what Troy mentioned and what others will follow up on, is the increase in cost of specialty meds. And when we began the high deductible plan in 2008, there weren't a whole lot of specialty meds around compared to today. What we found, though, is that with one fill, people can hit their $2,500 $2,500 annual deductible, and maybe even their $5,000 annual max. So from that point forward, there's no cost sensitivity on the part of that member as they use healthcare services. So we tried to be creative in thinking about how we work with a new vendor in terms of finding a creative solution to that particular situation. Copay cards are being widely used by our members, but the plan wasn't always capturing the savings. So people might use a copay assistance card to reduce their personal out-of-pocket costs, but that wasn't necessarily being effective in reducing the cost of the plan. Actually, sometimes there would be a perverse incentive where people would use the more expensive specialty medications because they're paying very little cost with those copay cards as compared to other alternatives that might have lower overall cost, but what the cost wasn't being mitigated for them personally by these copay cards. To assist us with this process, we began working with Health Strategy in 2016, which was a great partnership for us to develop. And at this point, I'll turn it over to Amy Ball so she can take it from here. Next slide, please.
Thanks, Ed. So I just want to give you a quick background on Health Strategy. Health Strategy is a leading pharmacy benefit consulting firm. We've been around for over a decade now. Some of the things that we do with our clients, like Ed, are contract analytics to determine what the opportunity is for them in the marketplace. We run those RFPs, negotiate those contracts. We also have actually back in 2006, created the direct-to-pharmacy contracting opportunity. So as Troy talked about NADAC, we've been doing that since 2006 with pharmacy chains doing cost-plus pricing, and it's been very effective for our clients. We'll talk a little bit about that today. We have not implemented that with the Archdiocese yet. We also customize formularies, and we're going to talk about that today as another creative opportunity that you need contractual latitude to do, but that can be effective. And sort of compare and contrast that to Rx saving solutions as well, since Candace talked about Rx saving solutions. We have about $60 billion of pharmacy spend under management. We work with employers, small down to 1,500 lives, up to the jumbo clients over 400,000 lives. We also work with some of the largest health plans in the country, and we've negotiated those agreements as well as helping them with strategy. And we have about 3 billion pharmacy claims in our data warehouse. We are the largest conflict of interest-free pharmacy benefit consulting firm in the industry. We do not take or accept compensation or fees from any PBM, and we don't profit or operate any reseller or coalition agreements. All of our agreements are direct with the clients. Our clients pay us directly. Next slide, please. This just gives you an idea of a little bit about who Health Strategy is and why we think we do things a little bit different in the marketplace, because we think that shifting responsibility from the PBM to the plan sponsor or the client, the employer in this case, is the best way to achieve some of the transparency, increase our flexibility, improve overall care, and reduce overall cost. And so today, the things that I have highlighted, this just shows you the current state where basically everything on the left-hand side is managed by the PBM today. And we as employer clients, and even in some cases health plans, have allowed that to happen over the years, because generally you're not pharmacists managing, you don't have pharmacists managing the benefit at these employer groups. So you have to have somebody do that for you. What we think the future state looks like is taking some of that responsibility on as a client. And certainly the Archdiocese has been willing to do that, as have many of our other clients. So if you look at the future state, you obviously need a PBM. You have to have a PBM to adjudicate your claims. And so that's very important, and we leave that responsibility with the PBM. But the other areas that I've highlighted are things that we as employers can do ourselves and take a portion of that responsibility, whether it's manufacturer revenue contracting directly with manufacturers, retail network contracting, mail order specialty contracting, formulary management, and then contract performance monitoring and management. Those are things we can do as employers and that really do decrease cost. And I'll show you some examples that we've got with the Archdiocese. Go ahead to the next slide, Sarah. So as you look at the Archdiocese trend over time, and this is a PMPM trend, less rebates that I'm showing on the bottom, there's a couple things that have happened. So we were engaged in middle to late 2016 with the Archdiocese, and we ran a market check for them. At that point, they were in a carve-in pharmacy contract with Anthem. A lot of small employers, even though they're self-funded, will end up with carve-in contracts within their medical contract. And, you know, a couple different reasons. It's easy to do. You assume there is some integration there, that they're managing your patient a little better. Sometimes that's the case, sometimes it's not. So we ran a market check in 2017 because we did say, based on what we could see in the marketplace, there was room for improvement. Now, as part of that market check, we were not able to get the current vendor provider to get to where we thought was market competitive for the Archdiocese. So at that point, again, through an integrated agreement, a carved-in agreement, sort of, we moved that business from Anthem to UMR, which OptumRx was the PBM for UMR, and that was effective 1/1 of 18. It was still an integrated agreement, but at this time, we actually inserted all of the language that we would put in a carve-out contract into that integrated medical contract. That was the only way we would agree to, you know, continue down this path of a carved-in pharmacy agreement, where when you look at many carved-in agreements, there's no language related to pharmacy, and the contract language really does drive what you pay for drugs. So you can see in 2018, when we look at our PMPM, and this is specialty and non-specialty combined, we'll look at these a little bit separately on the next slide, but specialty and non-specialty combined, our plan pay decreased. So we went from 67.58 PMPM to 61.85, and that's great. We can talk a little bit about 19, but 19 is a little bit of a fluke based on some utilization changes that we had. But if you look at that red trend line, you know, based on where the Archdiocese has been, we continue to expect increase in cost. And so it speaks to a little bit about a lot of what I've heard today. You know, we continue to chase savings. And I do not believe that we are ever going to get that solved until we get down to the real brass tacks of managing the pharmacy benefits, which is clinical improvement. And so one of the reasons, as you look at then 2019, we looked at the market and said, what's available in the market? We need to be able to implement creative strategies. We need more flexibility. As part of that market check, our current vendor would not agree to that. So again, we went to the market, and in at the end of 2020, moved that business effective 1/1/21. Because we were looking for more flexibility, we were looking for the ability to implement creative strategies that would help mitigate our trend long term. So to Ed's point earlier, not just that one-time fix, which we did see in 2018. Outside of the fluke in 19, I expect our trend would have continued to escalate up. And so in 2019, a couple of things we're looking for, and we're going to talk a little bit more about, are copay assistance programs and true accumulators. With the Archdiocese being a high deductible plan, true accumulation of what the member actually pays is very important as we look at spend. We also wanted the ability to customize our formulary. And this is where I'll talk a little bit about kind of a compare and contrast of managing your formulary versus something like an RX savings solution. So in 2020, the RFP moved the business from UMR, at that time the PBM is Optum, to Epiphany RX. And so Candace talked a little bit about Archimedes. Archimedes is the specialty arm of Epiphany. So Epiphany owns Archimedes. They're sort of one and the same, but you have the ability to carve out just the specialty PBM business, or you can take Epiphany, which is the non-specialty and specialty PBM management. At Health Strategy, we have done both. So I have clients with two PBMs, a non-specialty PBM and a specialty PBM. And we have clients fully integrated, and we have clients that have a PBM where the clients are doing what we're talking about today a little bit, all these separate components to lower their cost overall. So let's go on to the next slide. So here's a little bit more about the Archdiocese trend. Now we're going to look at plan paid PMPM. This is not less rebates. So we didn't have the ability before this presentation to separate the rebates out into specialty, non-specialty. So this is true plan paid PMPM prior to the application of rebates, because I wanted to separate out specialty and non-specialty for you to take a look at what, you know, most of you know is happening or you're seeing in your own data. Specialty utilization has always been a driver of trend at the Archdiocese, and really one of the reasons that I think Ed did reach out to Health Strategy and engaged us in 2016. Because prior to that, like most, you know, specialty was a good chunk of what was being spent in the pharmacy space. Some people haven't crossed that 50-50 threshold yet, but we crossed that in 2016 at the Archdiocese, where 50% of the plan spend was on specialty drugs. And that's well before many other clients crossed that barrier. So specialty has been a big issue for us for a long time. In a plan the size of the Archdiocese, so that, you know, 3,000 life plan, a couple of rare disease patients with high cost specialty meds can make that trend very volatile. And that's part of what we saw in 2019. One of those members moved actually to the medical benefit. So to Candace's point, it is really important, if you can get that data, to be able to look at that in aggregate, because we thought, oh gosh, that's great. That member's either no longer part of the plan or they're not taking that drug anymore. Lo and behold, that member was filling it under the medical benefit. So although it looks like savings to us, we aren't counting that as savings because we still, as the Archdiocese, spent money on that member. So when you have those rare diseases, it's really important to understand the volatility that can have in a small plan. And so when you look at our spend on specialty projected, we're significantly above that. And there's several reasons for that. So that was really a driver. When we looked at that RFP, we said, who can help manage specialty aggressively? And not only from a costing perspective, because previously you saw that we decreased spend under Optum, better contract language, better rates, but that is short-lived. So you can, we want our clients to have the best rates in the marketplace, and we generally get those for them. But that can be short-lived. And with these rare diseases, you have to be able to manage the rest of your benefit aggressively to be able to get through the costs associated with those rare conditions. So in beginning of this year, we implemented with the new PBM, and that was Epiphany RX. And one of the things that we're doing with them, and many of you may be doing these with your PBM as well, is copay assistance, and doing it in a way where it benefits not only the member, but the plan. Epiphany has found a way to do this with specialty and non-specialty medications. So many of you have probably heard about doing it with specialty meds. That is where I would say the overwhelming majority of the savings are. But we're also doing it with non-specialty meds because there's a lot of non-specialty meds like diabetes that are not inexpensive for the member or for the plan. And with the high deductible plan and the 30% cost share after you meet the deductible, it can be a significant financial burden for the Archdiocese membership. We also implemented true accumulation. Copay assistance dollars do not accumulate if the member did not spend that money. And so Ed can testify that when we moved the business in 2017, he had a member call and say, hey, I see we're moving PBMs, and I use the copay assistance card for my Humira, and it allows me to meet my benefit very early in the year, so the rest of my healthcare is free for the year. Don't be fooled. Members are very educated about how these programs work and how to, I would say, game the system in a way that does benefit them as well. But we understand why they do it. Healthcare is expensive for them. And so we're working with Epiphany. They're working with members to lower the members' cost, but at the same time, lower the plan's cost. We'll talk a little bit more about that. We also have the ability with Epiphany to customize the formulary. And at Health Strategy, we make sure that all of our clients in their contract have that contractual latitude should they want to do that. We have clients that exclude a few drugs to those that may have a full custom formulary where they make every single drug coverage decision, and we help them do that. So when we started with Epiphany, we have, and we'll talk a little bit about this as well, Health Strategy has what we call a low-value drug exclusion list. And so these are drugs that come to the market, don't provide any clinical benefit over what might already be available in the market. Sometimes it's silly drugs that are combinations of drugs you can get individually that come with a price tag of $2,500. My poster child used to be Duexis. That's now available generically. I don't care if it's brand or generic, it is still a drug that doesn't provide significant value over taking the two individual products separately. Many clients across the country, not many of ours, but many employers across the country paid millions of dollars for a drug that they did not have to pay. And this is where we start to differentiate between maybe an RX savings solution versus simply customizing your formulary. I often explain a formulary as a consumer guide to benefits. And, if we have a product on tier 1, we say that's a product that provides value and at a lower cost. If we have a product on tier 3, that's a product that we say there are options available on tier 2 and tier 1 that can get you the same outcome, but you have to pay a premium for this product because it's more expensive. And so we like to use that as what I call a consumer guide. And so when we decide not to cover a drug, we're saying that there are options available for you on the formulary at a lower cost, or it may be available to you over the counter. In addition to implementing our historic low-value drug exclusions, the Archdiocese is participating in our quarterly new drug to market review. And so on a quarterly basis, we go through every new drug that has come to market, new generics, new line extensions, new molecular entities, medical drugs, to make our clients aware of what has come to the market. And then we recommend either coverage or exclusion based on the clinical data and the cost of those drugs. We share that with our clients. They have the final decision as to whether they want to move forward with any of those exclusions. And so some PBMs are not willing to let you do that. And many of the reasons center around rebates. When you think of my poster child Duexis, that drug had at any point, a 70 to 80% rebate. And so when you know that, to Troy's point earlier, when you know that that's a revenue stream for a PBM, that's the reason that drug is on the formulary. And so we say as a client, take over some of that responsibility and say, with the knowledge of how that drug provides clinical value, do you want to cover that on your formulary? And so you have to have contractual latitude to do that. And then one of the things that, we've heard a lot about, and I, saw on presentations today, and I think that was in Troy's as well, is GoodRx. It was in Gloria's also, is the use of discount card programs. Every PBM has one, and they're always talking to you about that as well. So if you exclude a drug, hey, do you want to use our savings program to let that member access a better price? I could talk all day about that as well, but we'll skip that for now. But one of the things that Epiphany is doing is allowing the use of GoodRx and allowing the member to submit a direct member reimbursement claim to the PBM, and we'll accumulate those dollars if GoodRx is the lower price. Now, we are not going to accumulate more than what they would have paid under the plan. So if they would have paid $50 under the plan and they can get it for GoodRx at $25, great, we're going to accumulate that whole $25. If they could have got it under the plan for $10, but they unfortunately paid $50 at GoodRx, we are not going to accumulate the full $50, only what they would have paid under the plan. So it does give the member some flexibility if they are a good consumer and they look at the formulary and they look at GoodRx and they look at pricing under the PBM agreement to be able to be a good consumer of their dollars. We also negotiated the contractual latitude, which we do with the majority of our clients, the ability to direct contract with retail, mail, and specialty pharmacies. We've been doing retail carve-outs and direct contracts for cost-plus agreements for really mail and retail since 2006. We also have done it for specialty pharmacy. We also have the contractual ability to direct contract for manufacturer revenue. And so all of those things give us opportunities to implement these creative strategies over time. If you look at the contribution to trend in the bottom right graph that I've got, this is specifically on specialty drugs. These are the drugs that are driving trend for the Archdiocese over this last year. Respiratory agents. When Trikafta came to market, it's definitely a drug used in more CF patients. More CF patients can now be treated. We have 40% of our trend was related to respiratory agents and driven by a couple of patients taking Trikafta. Antineoplastics kind of come and go. Any given year, those could be up and they could be down. In 2019, it was significantly down for the Archdiocese. Back up in 2020. Analgesic anti-inflammatories, a 20% trend. And the reason I show you these is when you talk about copay cards, there's a lot of dollars on the table for those agents. We have seen with other clients where we've taken these strategies, about a 50% reduction in the price of those CF drugs by accessing copay assistance in a way that benefits the plan. We know on the anti-inflammatories, Humira and Enbrel, non-needs-based $12,000 a year copay assistance. So we're working with the PBM in a way that they're able to capitalize on that upfront and long-term. We maintain the same cost share for the member over the course of the year, and it is a significant reduction to plan spend. You can go to the next slide. And one more. We're going to talk a little bit about copay assistance, just so everybody's clear. Copay assistance programs have been around for a while, And their goal is to lower member cost share. But they have unintended consequences for plan design because, again, remember the manufacturer of the product is paying for this. So if they reduce the hurdle of cost for the member is more willing to use their product. So remember I said sometimes you think of the formulary as a cost, or sorry, I'm looking at time and forgot what I was talking about, as your consumer guide to how to choose drugs. So we would put drugs in tier 3 that were more expensive when we knew there were lower cost alternatives available on 1 and 2. Copay programs take away that consumer guide and the direction that tier 3 provides, which is a higher cost product that may not provide any additional clinical benefit. And so it lowers the cost share on those, and then it changes those dynamics. So we've been talking to PBMs for years, since really a year after copay assistance programs came out. Help us find a way to maximize that, because it is impacting our plan design. It's making formulary management much more difficult. You know, copay cards as well as rebates have driven PBMs to force exclusions of medications within certain classes, but really to drive rebated products, because it was changing their dynamics of tier 3 as well. And so you'll see a lot of products now by PBMs being excluded in favor of preferred brands. And the reason that we've moved more to exclusions is to enhance rebates, but also to mitigate the impact of copay assistance cards, especially on the non-specialty side. And employer clients are funding these programs. If you look at if you look at AWP inflation on brand drugs, we continue to pay that higher inflation. Look at inflation on Humira, on Enbrel. These programs are being funded by you, the clients, through AWP inflation. You're paying more for drugs, regardless of how well you manage them clinically or what your cost share is. You're paying more for drugs when those prices inflate. And part of that reason is to fund these copay programs. So if you're paying for it, we say take part in it. And so that's why when we can and when it makes sense for a client, we are working with PBMs that can help us administer copay assistance programs in a way that benefit both the patient and the plan. True accumulator programs are important, especially for someone like the Archdiocese, where you have a high deductible plan. I call it a reverse accumulator program. You can call it a lot of different things, but it's ensuring that you don't apply manufacturer copay assistance dollars to the accumulators. So if to the member's deductible and their maximum out of pocket, if they did not truly pay for those dollars, the way it works now, and I think Troy showed that, maybe it was Gloria, the way it works now is those dollars are accumulating, and it's causing members to hit their deductible and hit their max out of pocket quicker because they're using those dollars funded through the manufacturer as their own. So we make sure that those don't accumulate, but we're still lowering the cost of that drug for the member. Then the copay maximizer program adjusts the member's cost share. Some are flat. You don't get as much savings with that approach, but when you use what's called a variable copay, you can certainly get a significant savings for the plan. And you can do that. You can front load that. You can spread it out throughout the year. And so you're maximizing those copay assistance dollars in a way that benefits the plan significantly. Most PBMs will offer this, and you have the option of using true accumulator programs and or their copay maximizer program. You can choose or use both. Next slide. One more, please. So we're going to talk a little bit about formulary management. This is a very busy slide, and I'm not going to walk through all of this, but the philosophy that we have at Health Strategy, we're not marketers, so very basic, low, medium, and high control philosophy. If you're a low control philosophy client, you want some control of your formulary, but you're maybe a little more concerned about member disruption. If you're medium control, you're not going to put things on your formulary that are patent extender type products. So the low control is going to exclude the Duexis. A medium control is going to exclude maybe an extended release product when the immediate release is twice a day. There's no proven improvement in adherence in once a day versus twice a day dosing. So this kind of gives you what those clients look like, as well as what the characteristics of that client might be. And so when you look at formulary philosophy for every single one of our clients. We have this discussion with them. We categorize them in these control buckets. And when we make our new drug to market recommendations, we make them in these philosophy buckets. So go to the next slide, Sarah. So when we make our recommendations, we either encourage the use of a new drug to market or we discourage the use of that. There's several different ways to do that. It might depend on whether you're on a PBM formulary or you're managing your own custom formulary with us. When we encourage use, we're generally putting that product on a lower tier. We want to make sure that product is covered. We might have step therapy, we might not. If we're discouraging the use, we're going to put that drug on a higher tier or exclude coverage altogether. And so we bucket all of our recommendations into these categories of whether we encourage utilization or whether we would discourage the utilization of that product. Next slide. And so when you look at all of these things that were implemented by the Archdiocese for 2021, our expected total cost savings, so savings to the plan and to the member, over 20%. Our network improvement with our PBM RFP process was about 1% of total cost. So we already had negotiated good rates in the marketplace in our 17 market check. So not a ton of rate improvement there, and we wouldn't really expect a significant amount. Otherwise, at Health Strategy, we're not doing our job. Copay assistance, plan and member savings, about 15% of total cost. The plan will actually only realize about 7.5% of that because they're a high deductible plan. They had high member cost share before. The other 7.5% will be realized by the members. And experience tells us we will exceed these. So we have done this with Archimedes on the specialty side and with Epiphany with another client. We expect to exceed these projections pretty significantly, actually, over the course of the year. We have not factored in any savings associated with true accumulators, but we do expect that to happen, and we're monitoring that on a monthly basis. How many people now are hitting their deductible and out of pocket on a month-to-month basis versus previous years? Clinical savings, about 3% of total cost there, and clinical savings are really what are going to help us with long-term trend. So we talked early on about long-term trend, and we're going to get some savings with our rate, but that goes away pretty quickly if we're just simply if we don't have good PA processes and ways to ensure that we're getting the right patient on the right drug. And so clinical savings of about 3%, and we generally see that double or triple over time. And then customized formulary savings, about 1.8% of total cost. And so when you look at formulary savings, that's very similar, I think, to what Candace showed with Rx Savings Solutions. And we have some clients who have not routinely managed their formulary, who've used Rx Savings Solutions with similar results to Candace. But those that manage their formulary, where we have looked at whether Rx Savings Solutions would help, it doesn't really provide a ton of value because we're making those decisions up front and helping guide our patients to the right drugs up front so that we don't have to talk about switching drugs. And when you're managing your formulary long-term, that's very helpful.